So we'll just start in a minute once she receives, Shweta.
Yes, sir. At the beginning only we have to present it, right? The PPT.
Yes, yes.
Just give me a 1 minute and then I will start the session, sir.
How can I change the slide then? Do I have a control with me?
Oh, no, sir. You have to just let me know next because slides I have to move accordingly.
Otherwise, I can start do with my mobile also. It's not an issue. If you share
Okay, sir.
can I share my thing?
You can do so
Yeah,
from your mobile also, but the thing is that you won't be visible. Your video won't be visible to us. Only your audio will be
Oh,
visible to
okay.
us.
Okay, that's fine. No worries.
Okay, sir. Sir, I haven't received any PPT, sir. Hello.
so we'll start with your mobile presentation.
Yes, sir, because I haven't received it yet. So can I give the brief introduction and then I'll hand over the session to you, sir?
So much, sir, for answering all the queries of the doctors. And thank you to all the participating doctors for your continuous participation. Thank you
Hello?
so much, sir.
May I
once
start?
again For your valuable time. So with the permission, we are coming to the session of
Hello.
May I start, sir?
Thank you.
The
Yes,
brief
yeah.
introduction.
Yeah, yeah, start with.
Okay. So good afternoon and welcome to one and all. I'm Shweta from Clarnet, a designated session assistant for a seamless experience of the session. Clarnet is very proud to be a digital partner for this event organized by National Neonatology Forum, Gujarat. The topic of today's session is lessons from experts' recent advances in BPD. Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Let's begin today's session, for which I would like to hand over this session to Prashant sir. Over to you, sir.
So on behalf of NNF Gujarat, I, Secretary Dr. Prashant Karya, welcome one and all to today's Neonatal Pathshala. Today's Neonatal Pathshala, we are having a lesson from experts, that is from Dr. Vishal Goyal. He is a neonatologist, chief neonatologist at Arpan NICU, Ahmedabad. And the session will be moderated by Dr. Biraj Thakkar. She is a neonatologist at Akanksha Children Hospital. So without taking much of a time, I request our speaker, Dr. Vishal Goyal, to start the presentation. Thank you.
Thank you so much for kind introduction, Dr. Prashant. Now I'm sharing the screen right now.
By the time Shweta, check your mail. I've sent twice on your mail.
Sir, I have checked also, sir. I haven't received yet.
It is Shweta, sweta.roy@clearnet.com.
Yes, sir. Yes, sir. sweta.roy@clarnet.com.
It shows delivered at 3:31 and 3:34 twice.
But sir, I haven't.
So just refresh your mail.
Yes, sir. I am doing that only, sir. It's not showing.
Can
sir.
you? Okay, now I started. Can you see my slide now?
No, Vishal,
Hello?
it's only a whiteboard.
Oh, I already started.
Just go to the next slide.
Yeah, I already started. It's not changing.
Sir, I'm providing you another mail ID, sir.
Oh, okay, yeah.
So sorry for the inconvenience. By that time, Dr. Biraj, you can just introduce the speaker as well as say something about Guj Neocon. Thank you. Biraj.
Yeah. Hello. Good afternoon, everyone. Sorry for joining a little late. So, Vishal is our speaker, and welcome Dr. Vishal Gohil. who has done his fellowship, and then after that he has done a specialization from UK, and he is the consultant at Arpan Newborn Care Center. So welcome Vishal, and today he's going to enlighten us regarding the recent advances in BPD. And regarding Gujneocon, we are organizing a Gujneocon on 28th and 29th of October. And 27th October is the pre-conference workshop. And Gujneocon is being organized at Madhuban Resort and Spa at Anand. So yeah, welcome you all and kindly register for the Gujneocon. And there are 3 pre-conference workshops. One is Focus, another one is NeoMap, and third one is the KMC workshop. So you may register for the workshop. We have already circulated the brochure for the Gujneocon. The link for the registration is already there in the brochure. There is also a website link where also you can go and can register and can have a look at the thing. And there is also an announcement for the abstract submissions for the PGs. So that guideline is also given on the website. The website is www.gujneocon2023.com. So I hope, and we will be waiting to welcome you all at Anand, and I hope to see you all in a couple of months at Gujneocon.
So thank you
Thank
so
you
much.
so much.
Now, yeah, Vishal, your screen is visible. You can start.
Yeah, so I just shared my mobile screen. Thank you so much, Dr. Prasad and Dr. Deepen, to give me opportunity to present the recent update on the BPD. In this update, generally, I just try to cover the pharmacological thing, not other than this one. If I go to the objective of this presentation, I will try to spend few minutes on the definition and pathophysiology, and follow by I will try to cover all the pharmacological management medication which who is using in the prevention and also management. Before I jump to on my presentation, I just want to share the one baby which we are currently managing in Arpan Newborn Care Center. So this is a baby, is 25-week male, single, no any antenatal steroid, no max cells, and antenatal period normal anomaly scan. Baby was delivered in emergency LSCS because of the labor pain and the bulging membrane on 23rd of May 2023. As well as birth, baby needed a surfactant, and we did transfer this baby in our NICU. Currently, babies are around 45 days old, and initially we face the few postnatal issue, which might lead to the bronchopulmonary dysplasia. So this baby had received a 2 dose of the surfactant, which is equal to 300 milligram per kg of phospholipid. Followed by baby had a pulmonary hemorrhage at day 8. We also try to prevent the BPD in form of to start early hydrocortisone, but unfortunately we stop it before on second day because of blood in stool. Baby has a hemodynamic signal PDA, but baby has not responded with the medical treatment, and still baby was on prolonged ventilation with feeding intolerance and excess suggestive of BPD. At the end of the lecture, we'll discuss how we manage this baby in our NICU. So as we know, there is an old BPD and new BPD. The BPD terminology will present in 1979, and at that era, we know that there is no any antenatal steroid, no any surfactant, no any fancy mode of ventilation, including invasive or non-invasive ventilation, and that's why I think this kind of X-ray we were seen in our textbook, which looks like a more inflammation, more fibrosis, and more airway injury. But after I think 2000, in after 90s to 2000 era, before 2 decades, the magical drugs was tried, and it was like for example, antenatal steroid, surfactant with non-invasive ventilation. Even in the volume gravity ventilation, we are getting a good response and survival in nowadays. But still, baby has developed BPD, and baby has still stuck on the ventilator. Even though doing this much thing with adequate ventilation, with the surfactant, with the nutrition, we are facing this kind of problem. And if you see in the world-based center, still they are facing this kind of problem. So why is it so? Does it as anything involve like genetic or perinatal factor? So this is just pathophysiological picture. If you see there is a lung development, you can see on the upper part of the slide. And if you see the gestational age 24 to 36 weeks, baby did not have any alveolar development yet. And mostly physically less than 30 weeker baby who born early has still in the canacular and saccular stage, and they have severe immature lung, and which are more sensitive of the mechanical injury, or either there is no any antioxidant protection, there is a low compliance, there is a chest wall is very compliance. So that's why we are facing this kind of problem after the birth. And again, even doing a minimal support, the baby, few babies are delivered with a good condition and require only non-invasive ventilation. Still, minimal support, baby might have developed a BPD. Even the antenatal glucosteroid, antenatal corticosteroid might potent inhibitor of the DNA synthesis, and it can also diminish the lung repair and the growth. So various factor is involved to develop the BPD. So till now, there is not a single intervention has proved successfully that why novel the therapeutic intervention continue to be sought. So if we go for the definition, I'm not going to detail in the definition because the definition are changing since 5 decades. They update, I think the NICDS update in 2000, and they divide BPD in mild, moderate, and severe BPD. But in 2019, the BPD definition they developed on base of the mode of the oxygen supplement. If any baby who require no any oxygen, there would be no BPD. In the grade 1, there would be low flow nasal cannula. If any baby require more than 2 liters of the flow, then it would be grade 2 BPD, or either NAPPV, then it would be grade 2 BPD. Any baby who is on the invasive ventilation, then it would be grade 3 BPD. So let's take the medication one by one. If you remember the logo of the Cochrane, the logo of the Cochrane is made up of the trial which are done on the antenatal steroid, and it it has a tremendous response after that it improve the survival of the preterm baby. Why is it so? Because it improve the maturity of the lung by increased surfactant protein, by improving the pulmonary blood flow, and ultimately it improve the oral respiratory function. But if you see the research, it improved the IDS and mortality, but they haven't mentioned regarding the BPD. And they did the meta-analysis on 2020, and they show that the baby who received antenatal steroid, they have more BPD as compared to not have in the. So that means the antenatal steroid might not have prevent the BPD, and it is because day by day we are saving the small and small baby, and most of people in the world who hello, can you hear me? Can I continue? Hello. So ultimately the antidote steroid is it's increase the overall survival of the preterm baby, and due to the decreased mortality as combined outcome of BPD or this. We know the ACO is OG guideline, so nothing new about that one. We should offer the anti-steroid all the mother who are between 24 to 34 weeks with the risk of the delivery within 7 days. Even in the Western country, they are now offering till 22 weeks to save the extreme preterm baby. We can also offer to the woman who is between 34 to 37 weeks of the gestational age, uh, with the risk of preterm delivery within a 7 days, who have not received antenatal steroid. Surfactant. Now there is another magical drug which ultimately improve the survival of the preterm baby. But does it prevent the BPD? Let's see. So mechanical action, we know it decreases the surface tension, increase the lung compliance, prevent the mechanical injury. But there's a one trial which done in 2010, which enrolled the 24 to 28 weeker of the baby, and they delivered the surfactant via CPAP or either by intubation within the first hour of life. And surprisingly, they found that there is a similar BPD in both groups. But at same time, the timing of the surfactant is very important. Followed by there is a few trials show that if you give the surfactant within a 2 hours of the life, or either you can extubate within a two hours on the CPAP versus selective surfactant and on the mechanical ventilator, which show that it decrease the incidence of the BPD. But in 2050, there was a meta-analysis on inshore. We show that there's no difference in the BPD. That means any baby who we are giving the surfactant via inshore, even the 5 minutes of the bag and mask ventilation, or either few the TP's resuscitation might damage the lung and leads to the BPD. So that's why the LISA is come into the picture. The mist is come into the picture. So there's a few trial which they deliver the surfactant via small catheter and they give the CPAP during delivery of the delivery of the surfactant, and they show that there is no difference in the outcome, but there is a less BPD in the mist group. That means the non-invasive delivery of the surfactant is more promising to prevent the BPD. They also try with the surfactant via Langer mass array, but it does not have any makes any difference. Still, there is no any data on the surfactant via nebulizer. So this is a small video which I show you. Okay, sorry. So there's another beep trial. So people are still thinking that should we add anything on the surfactant. So there's in 2018 in the Turkey they did the beep trial and they mixed the surfactant, particularly Saronda, with the budesonide versus only surfactant, and they found that there was a less BPD who has received a surfactant plus budesonide. But the limitation of the study is there's low evidence trial, there are small in number, and they're done with the surfactant. Currently, there's a new trial, is big trial is going on in the Western country with the Curacao. So let's wait for the result. There's also they try with the enol nitric oxide. So they enroll the less than 28-week baby who is stuck on the ventilator, and they give between 7 to 14 days with the enol nitric oxide. And but unfortunately, they fail to demonstrate any benefits. So at conclusion, if you think about the surfactant, the LISA has a promising role to decrease the BPD. Another thing is the surfactant with the budesonide has some role, but still it is low evidence trial and more research is required. There's a small video of the LISA which we done just in the morning. Hopefully it will be work. I think it's not playing on the screen. Sorry for that one. So now it's the caffeine. So we know the caffeine. The caffeine is mostly we use in the apnea of prematurity, and but it has another advantage. When they did the CAP trial, at end they found that it decreased the BPD with early administration within a 3 days. Still, they think it should be give us a caffeine as early as possible or either immediately after the birth. So currently they are doing a CAF room trial in which they enroll the 25-weeker to 30-weeker of the baby, and they give the caffeine in the delivery room 20 milligram per kg within a 10 minute of the life 10 minute of the life, and still it is in under trial. Also they think about the high maintenance dose. Should we give, because based on the CAP trial they also thought that should we give a more caffeine to prevent the BPD, but at same time it decreases the BPD, but it has a low evidence. So currently we have to give a normal maintenance dose of the caffeine. It has also some side effects like tachycardia, tachypnea, or sometimes baby has a feeding intolerance. And but there is also some myth that it is associated with the NEC, but none of the trials show that it has a associated with the NEC. Let's talk about the postnatal steroid. Everyone likes the postnatal steroid and they think about the diet and everything. But my question would be that should we give early steroid or late steroid? If we decide the early steroid, then which steroid? Should we give a dexamethasone or hydrocortisone? If we think about the less steroid, then should we think about the dexa or hydrocortisone? And last would be which criteria. So let's take one by one. In case of the early steroid, they on the base of dexamethasone, there was a 21 trial which already done in all over the world, which show that it decreased the BPD and ROP. But at same time, it increased the GI bleeding 2 times. It increased the cerebral palsy and neuro disability 1.5 times. Again, and same time, there would be a high chance of the hypertension and hyperglycemia. So based on this trial, we can't recommend the early steroid in form of the dexamethasone. Another is a Premilog trial, which is a famous trial nowadays, which happened in between 2016 to 2018, which include the early hydrocortisone. They enrolled the less than 28-week baby, and they started the hydrocortisone 1 milligram per kg per day, twice a day for 7 days, followed by 0.5 milligram per kg per day, once a day for 3 days. As we and results show that it improves the BPD, no short-term or long-term difference. They also follow the 2-year follow-up, and it does not make any difference in the outcome. But at same time, it improves the BPD, and they enroll these babies within a first day of life. So based on this study, we should offer in 28 weeker if in your unit has a high BPD rate. There's a dilemma. Those who are using the hydrocortisone as a early for the prevention, should we continue with the PDA treatment, or either should we give with the ibuprofen or with the indomethacin? But none of the there's nothing mentioned on the trial because both have a same side effect. Like we are just worried about the ileal perforation or stomach perforation per se. Late steroid. So everyone's favorite, I think, the DART protocol, but the DART is not double A, it is only one A, which we call dexamethasone or randomized control trial. This trial was done in 2009, in which they enroll less than 28-week baby and less than 1 kg baby who are dependent on the mechanical ventilation at first week of the life. They give a 0.89 milligram per kg over 10 days, and they just started after the 1 week. Then what would be the result? So they show that it facilitates the successful extubation in more infant by 10 days of the treatment. However, the BPD at 36 weeks of corrected age, the CP at 2 years of the age, mortality and was remain unchanged. That means if you give the late steroid to high risk of the BPD baby, then it decrease it improve the outcome. At same time, it is not increasing the cerebral palsy. So till now, I think we are using a DART by saying that it is not decrease the neurodevelopment outcome. When they did the meta-analysis or restudy the data in 2014, they came to know that if they give the lowest BPD rate was noted when you give the dexamethasone between 2 to 7 weeks of the life. At same time, they also study on the side effect. It did not increase the GI bleeding or cerebral palsy. As we discussed, it has unchanged with the hyperglycemia, ROP, and hypertension. This is a new meta-analysis which just released in the May 2023, and I think this article is very important who are dealing with the severe BPD case in their NICU. Basically, this study is enroll the less than 27 weeker of the baby, and they make a pair of the cohort. They involve 476 pair baby. Before starting the dexamethasone or hydrocortisone, they calculate the pre-treatment risk of the death or grade 2 or 3 BPD. Any baby who has a, uh, uh, risk of the BPD more than 50%, they give the dexamethasone and they follow that baby for the 2 years. So they enrolled data between 2011 to 2017. They did the follow between 2013 to 2019, and they did the research and analysis between 2019, and they finished just last year, November 2022. And surprisingly, they show the result that if you give the steroid to the baby who has a high risk of the BPD more than 50%, it ultimately improve the outcome in form of neurodevelopment insufficiency. And they also noted when they give the steroid in the low risk baby, it has a more CP, though more neurodevelopment insufficiency. So if I summarize this article, the if you give the dexamethasone in the low risk of the BPD patient, like any baby, like you can use the BPD calculator for that one, currently available in the Google in 2022. And if you calculate the risk, if it is suppose that baby has a less than 30% of the risk, and if you give the steroid, it might not helpful for that baby. Ultimately, it increase the CP. But when you give the high risk baby who has a BPD calculator showing the risk more than 50%, then it show that it improve the outcome and the CP rate is very low. There's another trial like with the hydrocortisone, late hydrocortisone, that they give a 72.5 milligram per kg over 22 days in mechanical ventilated baby, but they could not found any difference. So that means the late hydrocortisone is not recommended now. There is no any role of the inhaled corticosteroids. They try in the neurosis trial in which they give the budesonide from day first till 32 weeks. Unfortunately, they show the improvement in the BPD, but mortality was high. So, if I summarize the postnatal steroid, early dexamethasone is not recommended as we have seen high CP rate and high GI bleeding. Early hydrocortisone, it is promising, still more research is required, but we can recommend it in the high risk group. Late dexamethasone, as we discussed, we got the latest update for 2023, which suggests that if you give in the high risk baby, baby might get benefited for that. And if you give in the low risk baby, it ultimately decrease the outcome. It has a more neurodevelopment insufficiency. And late hydrocortisone is not recommended. Diuretics. We know the diuretics, and I think diuretics is frequently used in the BPD and in the Western country, particularly like USA, Canada, Australia, in UK, and even in the Japan, they are using like around 80% as off label. In the Japan, one of the articles show that the 80% of baby was discharged with the oral diuretics. But why they start the diuretics? Is there any rationality? When they started using the furosemide, they used with the RDS because in the RDS there would be fluid in the alveoli and it decreased the fluid. Ultimately, it increased the gas exchange. It improved the lung compliance. They did the lots of study on the furosemide, but they could not found any effect to prevent the BPD. At same time, they also found the electrolyte imbalance like hyponatremia, hyperkalemia, metabolic bone disease. Ultimately, it activated the osteoclast and degraded the osteoblasts. So it is even worse. And also they found that the baby has a weight gain issue. So ultimately, there is no any difference, no change in the BPD or hospital stay. So people think, should we start with, because of side effects, should we think about the potassium sparing diuretics? So even they try with the spironolactone and hydrochlorothiazide. And two randomized controls show that it has a transient improvement, but when they stop the therapy, it did not decrease the number of the days. And still, the baby has the same side effect, metabolic bone disease, and the hypertension. So my question would be, still we are thinking that why babies improve on the diuretics in transiently. Does the pulmonary edema is a part of the BPD? I think yes. Hydrocortisone and spironolactone right diuretics as compared to the furosemide, based on the trial, based on the history, not. Should we restrict the in the HSPDA? In the few Western countries, they are using diuretics in the HSPDA, but I think there is no role to prevent the BPD. And nebulization not yet tried. So if we go for the conclusion, none of the RCT show that it decreased the hospital stay and oxygenation. But in 2019 article, pediatric medical group from the USA, when they collect the data retrospectively, and they show that furosemide is decreased the BPD rate. but ultimately there is a no randomized control trial. Due to the side effect and absence of the benefit, chronic use not recommended. Quotidian sparing diuretic has no additional benefit. However, the sporadic course of the furosemide may be considered in the preterm infant with worsening respiratory status. Let's talk about the end state. So there's lots of evidence show that any baby, particularly extreme preterm, who has a large PDA more than 4 days, it always associated with the BPD. So I think that is the reason people try to close prophylactically. There's a lots of trial with the indomethacin, and we know it doesn't make any difference to reduce the rate of the BPD and duration of the oxygen with the prophylaxis. We also know about the ibuprofen. People try to close the PDA with ibuprofen prophylactically, but it does not decrease the incidence of the BPD or the death. This is a two big trial is going on in the UK, which called Baby Oscar trial and Benedictal trial in the Canada. They are just enrolling the baby extreme preterm less than 28 weeker, and they try to close the PDA prophylactically. Till date, it is not promising. They already collect all the data, and I think they might release the article in this year, but still require more information. So, at conclusion, prophylactic closure of the PDA is not recommended. Vitamin A. So we know that the vitamin A in retinol level is very low in the preterm who has developed the BPD. So that's why in 1989 they try to give the IM vitamin A 2000 international unit to alternate day for next 12 dose. But they saw the improvement in the BPD. So they again try the randomized control trial, and they show there would be some effect to prevent the BPD. But at same time, it is very costly and it is very painful for the extreme premature baby to receive the IM injection for alternate day for next 12 days. So there is a question for the neonatologist: should we give or should we give the vitamin A as a IM? It is worse for the baby. I think it is no. So they think about the vitamin A, oral vitamin A. So there is a two trial already done, which include the 5,000 international unit per day or 10,000 international unit per dose alternate day for 28 days. Unfortunately, they haven't shown any difference in the prevention of the BPD. There's a new trial is going on, which is a phase 3 trial, and it is called NeoVit trial. And they are now giving the high dose of the oral vitamin A, 5,000 international unit per kg per day for 28 days on the BPD and the mortality. Yet it is there enrolling. So conclusion wise, routine IM vitamin A cannot be recommended due to the minimal benefit and associated discomfort. Bronchodilator. We know that when baby has a bad lung, if you give the bronchodilator, it improves the compliance of the baby, it decreases the resistance. But in the randomized control trial, it show that it has a short-term improvement, but not reducing the BPD and the death. This is one big trial, Neosis trial done, and we discussed previously that it decreases the BPD, but in absence of the mortality. And metered inhaler, there will be no any effect for the prevention of the BPD. Pulmonary vasodilator. So we know that any baby, extreme preterm baby who has a BPD, again, with if baby has a pulmonary hypertension, then it has associated with the more mortality, increasing mortality. Unfortunately, none of the randomized control trial on the inhaled nitric oxide with the BPD. All the trial which has been done with the preterm with the needle nitric oxide, not with the BPD. But they also did not show any benefit. It did not decrease the BPD in the preterm baby. These are two famous trial done in the Western country, Nuno trial and Uno trial, and which show there's no any difference on the BPD. And recent meta-analysis on the inhaled nitric oxide in the preterm, they show that black infant treated with inhaled nitric oxide had lower incidence of the BPD death and compared to the placebo. And there is another trial, no CLD trial, in which they offer the prophylactic inhaled nitric oxide. They doesn't show any improvement in the BPD, but they found that when they give the inhaled nitric oxide to the preterm baby, There was a lower use of the bronchodilator, inhaled corticosteroid, postnatal steroid, diuretics, etc. So, as conclusion, the inhaled nitric oxide not routinely used or prophylactically, but can be considered in acute crisis with the pulmonary hypertension. Like any extreme preterm baby who stuck on the ventilator did not improve with the 100% oxygen with HFOV or either high ventilation setting, we can offer for a while. Sildenafil. So in sildenafil, we know it has the same mechanism with the inhaled nitrogen. Ultimately, it increases the cyclic GMP. It relaxes the pulmonary vessels, and 2019 meta-analysis with the sildenafil show that there is an improvement in the respiratory score in 2 to 7 days, and improvement in the pulmonary pressure in the 1 to 6 months in the preterm with the BPD with the pulmonary hypertension without any serious side effect. But for the prevention, I think we should not give in advance. There is no any direct correlation with the BPD. There's also one trial is going on called SILD Safe trial, and it is a double-blinded randomized control. Hopefully, it will come up by next year. So, by conclusion, the sildenafil can be used in the preterm with the BPD with pulmonary hypertension patient after consulting with the cardiologist and pulmonologist. Currently, the evidence is very low, and there's no role of the prevention for the sildenafil. Bosentan, again, it is a non-selective endothelium antagonist. And in animal study, they show the improvement, but in human study, there's no human study till done till now in the preterm baby. Macrolides. So in the past, the people found that ureaplasma colonization is more common in the BPD patient. And we know that BPD is associated with the inflammation. So they start to give or try to treat the ureaplasma with the erythromycin. And they try, but there was no effect on the BPD. And opposite side, it has a more side effect. So they try azithromycin, and recent trial they done between 24 to 28 weeks show no any significant improvement in the BPD. There's a one famous trial is going on in the UK called Aztec trial, in which they are giving the IV azithromycin for the 10 days, and they enroll the less than 29 weeker of the baby. Currently, they already collected data, and they are just doing an analysis. Till now, we could not have any data further. So at conclusion, we can offer to the we should not offer the routine prophylaxis in the BPD prevention, and because we do not have any proper dose, we do not have any proper timing of the therapy. Should we give IV or oral? So we do not have any evidence to give the azithromycin as a prophylaxis. Future direction. So I'm not going to spend so much time on this one. This is a stem cell therapy, and mostly they are giving right now mesenchymal stromal cell. All have a same mechanism. It facilitates the healing by entering site into the injury, promote the cell growth. It increases the cell proliferation and the angiogenesis. Ultimately, it also decreases the inflammation, decreases the fibrosis and oxidation. Currently, phase 1 and 2 study is going on in Spain, Korea, and Vietnam and China. Erythropoietin has the same effect like the stem cell therapy, and the peanut trial, which they try in the preterm, it does not make any difference in the BPD. Also, people try DHA because it has anti-inflammatory and antioxidant property, and true trials show no any significant difference. Clara cell protein, which is also have a same action anti-inflammatory, and it is a potent biomarker for the BPD, but does not make any difference in the BPD. Pentoxifylline, it has also anti-inflammatory property, and currently there is no data or limited data available which showing the prevention and treatment of the BPD. Ultimately, there is nothing available in the world which can prevent the BPD right now. And there's another promising drug which people are start using, human insulin-like growth factor. But I think they show the promising result. But ultimately, it will take another 5 to 10 years to come up in the market. So I will try to summarize the take-home messages, and followed by we'll discuss the case which I told in the first slide. So if we summarize the thing, antenatal steroids have no evidence to improve the BPD, although it improves the survival. In the surfactant case, Any baby who has a spontaneous respiration, specifically less than 28 acres, we should offer the LISA because it prevents the BPD. Surfactant plus steroid, there is a low evidence, some role, but still more research is required. In case of the caffeine, each and every baby who are less than 30 weeks has to be give caffeine within a 72 hours of the life because it is the only drug which prevent the BPD, which we seen in the CAP trial. If I talk about the postnatal steroid, early dexamethasone not recommended as it has a more CP and more GI bleeding incidence. Early hydrocortisone, again, it is a promising, recommended in the high risk group. If your unit is doing taking care of the less than 28 weeker, you might start you might start early hydrocortisone to prevention of the BPD. In case of late steroid, if you give the high risk baby, ultimately it improve the outcome, which show in the latest current trial. And maximum effect will get between 2 to 7 weeks of the life. Late hydrocortisone, again, there is no any recommendation and it does not make any difference in the prevention of the BPD. NSAIDs prophylactic closure of the PDA not recommended in view of the BPD. Vitamin A routine use not recommended because or maybe used in the center where in which there is a high BP rate. But again, the IM injection, it is difficult to give in the extreme preterm and it is very painful for the little tiny baby. Diuretics. None of the diuretics show any improvement, but still we can use in the preterm baby if if baby has a worsening respiratory status. But when you start the diuretics, you need to try to stop as early as possible. Don't use chronic. Just repeat the electrolyte every 4 to 7 days and look for the weight gain. Enal nitric oxide not routinely used, not recommended for the prophylaxis, but can consider in acute crisis with the pulmonary hypertension. Sildenafil again can be used with the BPD with the pulmonary hypertension after discussing with the cardiologist. In Western country, any who stuck on the ventilator or who discharge with the high flow or minimal oxygen, they generally discharge with the diuretics and the sildenafil, and they are repeating the electrolytes every 1 to 2 weeks, and they are also thoroughly monitoring the weight gain. Bosentan not routinely recommended. Macrolides also azithromycin not recommended as low evidence. We do not know the dose and duration. That's why. Inhale bronchodilator can use in some of the patient for a while to decrease the airway resistance and improve the compliance, but not recommended as routinely. None of the newer therapy is promising yet, and all are in the trial phase. So let's talk about the case one. This is a case which we managing currently in the under Arpan, who is a 25 acre and no antenatal steroid, has an issue postnatally with a 2 dose of surfactant pulmonary hemorrhage at day 8, followed by stuck on the ventilator. 3 times PDA is failed to manage by the medication, and there is a feeding internal. So anyone can comment on this baby, how we can approach further. So in this baby, at day 31, we found there's a large PDA, and we thought that it might be contribute to the PPD, and we closed this PDA with intraluminal closure. It is not a surgery, and I think it is youngest in the Gujarat who are closed by the catheter. After that, still baby did not have any improvement, nor not much improvement on the ventilator setting. And when we calculate the BPD score, it was, I think, more than 50%. So that's why we start the DART as because baby has a high risk of the BPD. And current 2023 articles show that if you give in the high risk baby, ultimately improve the outcome, improve the CP, improve the neurodevelopment insufficiency. After that, within 2 days, baby is extubated on the day 35, and currently baby is on the CPAP of 30 to 40% of the FiO2. Still, baby does not have much improvement in form of the FiO2. Baby reached the full fit we try to give a nutrition as much as possible, like 110 kilocalorie per kg per day. Baby is on the caffeine. Baby does not have any inflammation or infection. USG head is normal. Then what next? Do we need to change anything? So if you see this slide, we just did the lung ultrasound before 3 days, and we just thought about the diabetes. Should we start diabetes on that baby? Because this baby has a pulmonary edema in form of, if you see in the lung ultrasound, there is a controlled B line, thickening of the pleura, and we know that the pulmonary edema is a component of the BPD. So if you start the diuretics, then we need to monitor the electrolytes, we need to monitor the weight gain, and we try to wean the diuretics as early as possible. But we haven't started yet because the diet is going on. Once we finish the diet regimen, we generally think about the diuretics. Thank you.
Thank you, Vishal, for such a nice presentation and compiling everything, past, present, and future regarding BPD. BPD is such a vast topic, but you just concluded and compiled everything in such a short time. I really appreciate that. It was a wonderful presentation. And yeah, we are ready to receive the questions. Is there any questions? You may put it in the chat box.
I tried to stop my screening, saying so I can see the video and everything.
Yeah. Stop sharing your screen.
Mm, yeah, but I'm happy to listen this question because I just try to came out for the
Yeah.
screen. So
Yeah.
Shweta, you
I
can
request
stop the
audience
screen
to,
sharing.
yeah, that's what he's trying. I request audience to put your queries in the chat box.
okay, now I can see. Yeah,
Is there any query? So Vishal, till the time they put the query, I just would like to ask you that, we have many times seen BPD spells. So I was just wondering that how you guys manage BPD spell, because it's sometimes very challenging to manage the BPD spell.
so generally
Patients
just
suddenly desaturate. Yeah.
yeah, so generally it mostly associated with the pulmonary hypertension when I see do the echo, and generally we try to involve the cardiologist to see that, because in if you do the functional echo on that BPD patient, you might not see the typical PPHN finding. So you might need, we are not expecting the TRZ, or you might not expecting the flattening of the interventricular septum. So generally they assess the pressure, and what we did in the overseas, they generally try to send that baby in the cath lab, and they generally actually measuring the pressure, and they start the sildenafil.
Uh-huh.
Or sometime baby is
Okay.
stuck with the BPD spell, we might put into the ventilator, and we sometime use as a nitric oxide as a rescue dose. And if that baby is come
Okay.
up with the sildenafil or with nitric oxide, we might discharge this baby with the oral sildenafil to prevent this BPD spell.
Okay.
And specifically,
And second thing
specifically we
regarding, huh?
specifically we are also facing nowadays that we are receiving the IUGR baby, and when you receive the IUGR baby who are like 600 grammer, but the correct the gestational age is around 30 weeks, they have abnormal pulmonary vasculature, and they mostly have prone to have this kind of spell. Initially, after the birth, baby did not have any major support, but once baby is reached to the more than 2-3 weeks, the oxygen requirement coming in the picture. We might need a CPAP. So in that case, we are worried, and mostly BPD spell we see in this kind of IOGR baby.
Yeah. So basically, in that case, you just go according to echo or the Western countries have
Yeah,
facilities available, then the monitoring at the cath lab, and
monitoring
then either start to sildenafil, or if required and the spell is
require.
too severe and the child is on ventilator, then start with the inhaled nitric oxide. So these are the two things which may work in the case of BPD cells. Yeah, second thing which you mentioned about the SGA, baby rightly mentioned, that is what my next question to you. Because as you mentioned about this early hydrocortisone, that is the results
Yeah.
are quite challenging and promising in case of early hydrocortisone. But is there any contraindication to start with early hydrocortisone? Because when the baby is SGA, as of my knowledge, probably we would like to avoid, or would you start, or it's still, like SGA is the contraindication or not?
As I remember, there's none of the trials show that they exclude the SCA baby. So generally they focus the less than 28 weeker, irrespective of the IOGR. So if you think about the 30 weeker, I think we should not give a hydrocortisone because the trials show that they enroll the less than 28 weeker. And if you see nowadays, the more than 28 weeker baby has a very, very less chances to have a develop the BPD. And there is no any absolute contraindication for hydrocortisone. You can start, but I think we should start in the less than 20 liter, not more than that. Even baby is less than 600 gram or less than 800 gram.
So in your unit, the protocol is to start hydrocortisone on day 1 for any baby who is less than 28 weeker. Is it so?
Ideally, yes, but we are still just thinking about, because there is a similar trial which we've seen with the Premilog, that the transient deficiency of the hydrocortisol in the preterm baby is very common, and they might be a baby is improved because of the we are giving a steroid, so there's more blood pressure, more stability in this preterm baby. So still now we are not using in 26 to 28 weeker, but sometimes we are using in the less than 26 weeker. And generally we try to enroll within a 48 hours, because with the PDA, I think it is difficult to give the ibuprofen or indomethacin with the hydrocortisone, because there would be high chances of the perforation.
Yeah. So again, the PDA, so after this Benedictus trial and Oscar, the things has changed a lot, always not to treat, whether to treat or whether not to treat. And then ultimately we are ending with the conclusion with this latest trial that not to treat the PDA, isn't it?
Yeah, but still in the Western countries, they are trying to close early if it is significant. But there's a one reason for that one. We do not have any medication who close the PD after 7 days. All the trial which done, in which they treated the PDA within a 7 days of life. If any baby, for example, have a moderate size of PDA, not that much significant, and if we left PDA with the baby, and after 7 days it become more significant, and when we try paracetamol, ibuprofen, or any medication, they are not going to close. So our biggest challenge would be to find the medication who treat after the 7 days.
Yeah, that dilemma is going to be there, whether to treat or not to treat. That's a big debate, and that's a totally separate topic other than this. Yeah. So do we have any other queries and questions from the audience? Is
So I
there
think
any
there are
questions,
no
Prashant, on the
questions.
YouTube?
No, I
questions
don't
on
think
the
there are
YouTube
questions
yet.
on YouTube also.
So then
So
he was very crisp and clear, so there are no confusion and no doubt.
Hopefully.
Yeah.
it was really a wonderful and short and crisp presentation. So I think
Yeah.
it was useful for everybody. So can I
I
request
think
Shweta?
I just try to cover for our PG student and the DM student and the fellow who are just going for the exam and they might be face the regular trial. So that's why I try to cover like that.
So 25 p.m.
Yeah, Shweta, can we have the certificates?
Yes, sir, just.
So on behalf of NNF Gujarat, I, Dr. Prashant Karya and Dr. Dipen Patel, we are thankful to everyone who was present in the talk, and we are thankful to today's expert, Dr. Vishal Goyal, for such a nice, crisp presentation. I hope it is useful for everyone. We also thank Dr. Biraj Shakkar, moderator for today's session. And thank you so much. See you on
Thank,
next Wednesday in Neodal Pathshala. Yeah.
Thank you
Prashant,
so
I
much,
have
Viraj.
one more announcement. Prashant, I have one more
Yeah, yeah.
announcement regarding ventilation workshop. So can I share my screen?
Sure, sure. Once, yeah, you can share now.
The-
Not an issue.
Yeah. Yeah. Can you see? I don't know.
We can see.
Yeah, but it's not like, the things are not properly seen. So basically, this is a neonatal ventilation workshop which we are organizing from on 19th and 20th of August. It will start from 1st of August, and there are two modules, Module 1 and Module 2. Module 1 is online module from 1st to 17th August, and Module 2 is offline module, that is 19th and 20th of August. And that is there at the Anand, Akanksha Hospital, Anand. So we are organizing this along with the Pramukh Swami Medical College in NF Gujarat. So the registration link is already there in the brochure, and brochure is already there in circulation. So those who would like to attend, kindly register. There are only limited 40 seats for ventilation workshop. So that is what the announcement was about. And Prashant, now you can go ahead with the rest of the things. The
Yeah, so
closing
thank
of
you
the
so much.
closing
And
remarks. Yeah.
Thank
yeah,
you so
we
much,
can,
Prashant, Dr. Biraj. Thank you so much.
yeah, so thank you so much, everyone. And see you on next Wednesday, 3:30 p.m. in New Hotel Pathshala. So we can end the meet now today, Shweta. Thank you.
Okay. Thank you.
Thank you. Bye.
Okay.
Bye.
Bye bye.
Thank you, everyone.